Hello and welcome to Macros with Mythili, the 18-hour show that takes a hard look at all the major macroeconomic issues and developments in India and overseas. This week we're going to take a hard look at an issue that, for all its import, doesn't seem to have attracted much interest in India: the new health policy. This despite the fact that it comes 14 years after the last health policy and impacts every one of us. I don't have to tell you the numbers, but just to put things in perspective, even after close to 70 years of independence, 45,000 mothers die each year during childbirth. That's the highest in the world. 43.5% of our children under the age of 5 are underweight and malnutritioned, higher than sub-Saharan Africa. And every year around 220,000 people lose their lives due to tuberculosis, again the highest in the world. So to discuss the policy, I have with me two experts in the field: Sujata Rao, former Health Secretary Government of India, and Indrani Gupta of the Institute of Economic Growth, Delhi, who belongs to a very rare breed of health economists in India. Welcome to the show, Sujata, Indrani. Incidentally, I can't help but add, but this is the very first macros discussion where both our experts are women. So double power to women. So let me plunge into the discussion right away by asking both of you in turn, why is there so much less interest and debate in the new health policy in India compared to, say, Obamacare in the US? Is it because nobody takes the policy seriously? Is it because, despite its very laudable goals, affordability, universality, reinforcing trust in the public health system and so on, the policy is really thin on how it's going to achieve these objectives? Sujata, you have pointed out elsewhere that there's really no correlation between the goals and the investment proposed. So let me start with you. As a former health secretary, did you find less interest in the higher echelons of government, like the PMO, when it came to health, than, say, foreign direct investment? Sujata?
Absolutely. Even today, health is really not a priority item at all. If you make a scale of what are high priority programs for the government, and that I see, and that is reflected in the fact that they don't give much money. And in the 70 years, the GDP allocated for health, public investment, is about 0.9 to 1.2. And that in itself shows that, health has never been in a development dialogue at all. And we haven't transcended and upscaled the dialogue to include health as a very critical component of health and development having an association. So I think it is this main reason that our policymakers and economists continue to look at economic growth, not look at the broadening definition of what growth should and development should mean. We do recite HDI, but we're not looking at poverty index and those kind of new tools that are coming up to show what deprivation means, what development should mean. So I think we've missed it somewhere in this country.
But why is that so, Sujata? If I could just ask you to supplement your answer, why is that so?
Just indifference, lack of interest. And more than that, the macroeconomic fundamentals, as you're an economist, we've never had enough money, and whatever we've had has gone into populism. A large amount of money goes in where the votes count. And that's a part of the political economy that we've been facing. And health has never really won them votes. And largely the middle classes, which have a big impact on the vote bank, and they're more articulate in the media, have been able to make their own arrangements by getting into private medical facilities. They have private insurance, and therefore they never really put this pressure on the government to say that you have to increase health budgets and make health available to all of us.
Indrani, as one of those relatively rare breed, as I said, of health economists in India, unlike, say, fiscal or monetary economists, how do you see that relative lack of wider interest in the new health policy? Is it because good health is still not seen as a basic necessity that the state must be held responsible for? And would you agree with Sujata that health doesn't seem to win you votes? To my mind, that seems very contrary. What could be more important to an individual than his health?
Yeah, thank you, Mythili. I do agree with Sujata, but I want to say something about the US. You mentioned the US Obamacare, so I'm just trying to respond to that as well. You said they made revolutionary changes in their healthcare systems, and I don't think anything like that has happened in India that would warrant that much attention. And the changes that they made had such far-reaching implications about their population, the way they run, the insurance companies, etc. I don't think in India we have seen major departures from our previous policies. It's been basically a kind of steady, continuous, low level kind of policy making, I'm sorry to say. And that is one reason why people haven't been focused on this. That's one part. The other part is that yes, we haven't really prioritized health. We know that from us, you know, almost constant stagnant level of expenditure as a share of GDP on health. And the prioritization, if the government doesn't prioritize, there's no reason to think why people would also actually you know, think about it in that sense. So debates and discussions around health policies really haven't taken place in our country so far. And I think it's also awareness on the part of the population about what good health is and how they can actually get better. Mostly we have focused on tertiary curative care, but very little focus has been on how not to fall sick.
Sujata, would you agree? Indrani says that there's nothing very fundamentally different about the new policy. But if you look at the fundamental debate really in healthcare, whether in India or abroad, it's whether we should follow the UK model of a publicly funded health service or the US model that relies largely on health insurance. And the latest policy seems to veer towards the latter, even though we've seen the limitations and indeed the dangers of going down that path. So my question to you is twofold. Is that the right way to go for a country like India, which is so poor? And or is publicly held funded health the only way that you can actually make any progress on the health front?
Well, Mythili, you know, there's a trade-off for every choice, and when economists or policymakers make choices, they have a responsibility to explain to us what are the implications of those choices. Unfortunately, in India, we long ago gave up the UK or the European model of socialized medicine, and we are very rapidly going and hurtling ourselves towards the US model as something that's excellent. Now, US has 2 points in its favor. One is, there is no doubt the best quality of care is really provided in the US more than any other country. But the point really is that, are we going to be able to afford placing or earmarking 20% of our GDP for health as US is doing? Now, US model is extremely fragmented. They have never paid attention to primary care. They are isolated, fragmented facilities that provide and focus on specialist hospital-oriented care, and a very high focus on drugs and diagnostics. Now, if we go that way, which is what is happening here, we will not be able to afford it, and it's just not a sustainable model for India given its low resources and huge amount of disparities. We don't have the basic minimum threshold of income to sustain such a high cost model as the US has. So I'm afraid it's going to be extremely serious if we follow that route. And insurance, as you know, and particularly when it's piled onto a multi-payer environment based on a fee for service, it's highly inflationary, and the costs are just going to go up. Where is the competition in health? You know, there is market asymmetry of information. The market failures are extensive. So I don't really see how the math is added up when planners say that, you know, we can go the US model with just this 1% of GDP public investment in our hand. Please do remember, US spends 9% of its GDP as a public investment in health.
Public health is not really a public good as economists understand it, because when one person avails a facility, it does reduce the other person's access since resources are not unlimited. Even so, would you agree with Sujata that for a country like India, it has to be treated as a public good and there is no alternative but for the government to get into the delivery, and it cannot abdicate its responsibility in this matter? Indrani?
Yeah, to a large extent I do agree with Sujata. There are health goods and services that are completely like public goods, and there are some that are less so. So I think we have to think of the division, the allocation of resources in a manner where we you know, use preventive promotive health services as the most public good kind of services, and tertiary care can remain a little bit on the top side where we can think of other ways of financing. But the fact of the matter is that yes, we must have, and I think I agree with Sujata, for lower levels of care, for primary care, it has to be that everybody should be able to afford such care, and these should be affordable and available. Now, one question that you raised is that is in the beginning was which model should we actually go with? And here I must say that we've never had that discussion or debate in the country about which model of universal health coverage, let's say, we should follow. We have many fragmented schemes of health coverage in the country, some that are very expensive and very comprehensive that cater to a small percentage of the population, and we have some very, very modest schemes for some other parts of the population. The rest of the population don't get any coverage at all. Now, in that scenario, we really, I think we are spending our funds for health services as well as for health coverage very inequitably, and we have to think of consolidation, merging and pooling and putting resources, especially because resources are scarce, and if you have scarce resources, you need to actually pool even more.
Absolutely. What we need most of all is a comprehensive health policy, and we are going to ask Sujata, we are going to ask you as a former bureaucrat, why is it that we are not seeing a comprehensive policy rather than these fragmented piecemeal approaches? But all that after the break, so please do stay with us. Welcome back. You're watching Macros with Mythili, and we're discussing the new national health policy with our panel of 2 women experts in the field. Sujata, before the break, of course, I had that slight dig at you saying that as a bureaucrat, what has the government done to have a comprehensive policy? But apart from that, the policy document talks of aligning the growth of the private sector with public health goals. Now, isn't that a bit naive, because the incentives for the private sector are entirely different, and at the cost of sounding slightly cynical, the private sector basically seeks to make money out of people's ill health. So how can that really be synonymous with public sector health goals? I think you've already spoken about this once before and written also about it. So is there something little missing in that?
Yeah, that's really sounds extremely contradictory, and it's only in some limited spaces like infectious diseases or where you can bring in a law and say whoever the provider is, he has to fit in with our protocols that we've laid down because it has a public health dimension to it. But in private care, it's going to be extremely difficult for government to be doing the so-called strategic purchasing and also keep the cost of care when you are not the only payer. That is the single most important. Government doesn't have a monopoly on the market. It is one of the many payers. So what is happening in Rajiv Arogya over here, though 85% of the population is covered, still it is a private provider today who has the upper hand in dictating prices, in dictating what services they shall provide, when and how. So the government is on a weak negotiating basis on this whole system of negotiating a PPP model. So I do worry about the fact that particularly in an environment where regulatory systems are weak, enforcement is almost absent, and they're using fiscal incentives to try and provoke and incentivize the private sector to provide care. It is a bit worrying because the prices are not going to be contained if there is no alternative to the private care in the market and government is buying the services. So I personally feel in this whole purchasing, in India, the way the model is turning out, I don't see any alternative to the fact that the government cannot just abdicate itself to being a steward. It has to be a provider of services as well. I really do believe that, for example, in India, in Delhi, AIIMS being there is a big price a cap on the prices because AIIMS is there and there's an alternative. If you remove AIIMS, I can tell you many of the prices in the corporate hospitals would just shoot up much more, and that's not my feeling, it's the feeling of many people. And this advantage that the government has in being also an equal, on par, a good provider of services, we are not exploiting fully, and we are thinking of that model that is bandied around internationally, that the state should be a steward and allow the players to provide services, the other stakeholders, and we just purchase care and regulate it through price. It's not going to be that easy.
So Yatha, that question was addressed to you. I was asking you that before the break, Indrani spoke about the need for a comprehensive national health policy rather than a very fractured kind of piecemeal kind of system. So as I said, as a former bureaucrat, what is your...
My take is that, we've been in denial for a long time, where we've not accepted private sector as one of the stakeholders, and we've only looked at government schemes and government programs as being the responsibility of the government. And that's an infirmity in understanding. We have not looked at health system as a whole, and that's the reason why we could never really come up with a comprehensive understanding of what kind of a health system should be designed for India. We were always only looking at our own programs where the government invested its own money. And even today, the minister thinks of himself only as a minister of health for the government budgets and the government programs. Till that understanding shifts, and like other ministers also take responsibility for what's happening in the private sector, unless we look at the whole system as a whole, we will never be able to come up with a comprehensive policy. The second is the deterring factor is the low funding and the low political priority that health gets. And there's no point in making comprehensive policies if you're not going to get resources to back them. Don't have the money. And to be honest, I was just saying, to be fair, the National Commission on Macroeconomics and Health in 2005 did lay out a vision where it did say there must be a health system and there must be a movement towards universal health care, where a lot of focus was given on building it up from bottom up. That's a primary care, secondary care, and then you move on. Then the high-level expert group in 2012 also came up with a comprehensive understanding of how we can design a health system. But you know, none of these reports are read, and the discussion continues to be very, very fragmented, because it is being led by subconsciously we're looking at what's going to be the money available and try to fix a policy within that. And that too, I'm afraid we don't do it well.
Absolutely. Ultimately, it all comes down to money. But Indrani, here if I can come back to the issue of the mindset, why is it that when it comes to a government's role in healthcare, why is it that they say the expenditure on, say, a road project or a power plant or any kind of physical infrastructure is taken as investment? But if you spend on health, it's immediately taken as expenditure in government accounts. Why is there this, double-handed kind of approach to healthcare, which is absolutely as much of an infrastructure as power sector? One is soft and one is hard.
I think the reason is that good health is invisible. You don't really see good health or well-being. What you do see is bad health. So it's easy to invest in a hospital because you know that somebody is ill and gets better. But preventive and promotive healthcare services are not seen as investment, because you don't get tangible, immediate, visible results out of that kind of investment. And I think that has really gone against the health sector. The fact that we do not really understand that good health really means higher productivity, lower morbidity and mortality, and therefore it weaves its way through the system into higher economic growth. That part of the argument has never been really articulated or debated on in India, and I think that's why we don't see investment in the health sector as investment. It's only expenditure. I think that the day we really understand what the original WHO definition of a holistic approach to health, and the fact that if you do not have ill health, that is when you are really doing well in a country, I think we would be viewing health sector spending as health sector investment. But that hasn't really happened yet. So we are really focused on tertiary care, on hospital care, and not really on the other primary care at all. I think it has to change, and it has to change very soon. I would say one thing though, to be fair to the new health policy document, I mean, it has said a lot about putting confidence back in the health, in the government sector, of the government taking the lead in financing as well as provisioning, and a bit of strategic purchasing may have to be done in any case. And as an economist, I must say that it may not be possible for the government sector to fund the entire gamut of services from primary to tertiary, and there would be gaps but the strategic purchasing has to be very well thought out, very well planned, with lots of checks and balances. But yes, the major focus would remain on public financing, and possibly a large part of it will have to be public provision as well.
Sujata, you also spoke about the need for funding, and government does want to increase health expenditure from the present 1.5% of GDP, which is one of the lowest in the world, to 2.5% by 2025, but says that this money must come from general taxation. Why has it been so difficult to think of a separate fund, after all in a scenario where the government has shown no hesitation in levying cess for almost everything under the sun, roads, higher education and so on? Why can't we have a health cess and use that money only to strengthen the primary health care? We already impose taxes on commodities like sin taxes, tobacco, alcohol, and foods which have a negative impact on health. So why can't that money be earmarked for health, Sujata?
But it can, and we've been having these arguments for several years with the Finance Ministry, saying that all the cesses that go for alcohol or on tobacco should be given back to us. The argument, the classical argument of the Finance Ministry is that all this goes into the consolidated fund, and it is from there that we're giving you your budgets. So you cannot have a separate revenue stream for yourself. But you know, so well, that's one way of looking at it. But the point is that they're not giving enough. And look at the alcohol cess in Tamil Nadu. It was just used for Amma canteens and a whole lot of popular schemes. They never really went to the health. Though I must dare say the Tamil Nadu health system is probably the best functioning in the country. But there's still a huge backlog in terms of, if you really see the amount of more work that needs to be done in the health sector there. So when you say, Mythili, your previous question, why don't we give priority? I'm just wondering how many health economists, how many economists have ever taken interest to see what is happening when sickness is predominant to your own productivity and your GDP. I mean, 12% of the reason why labor force absents itself is due to sickness. 25% of your savings by the self-help groups goes for hospitals. So if you really see the kind of money that the people are spending on drugs and medicines and so on, and the absenteeism on account of illness, if you really add it up, it really comes to quite a bit. And I have a feeling that the economists and the policy makers haven't really argued this whole sector out adequately enough for the politicians to give it the priority that it deserves. And this is a bit of a failure in my opinion of all of us.
Indrani, Sujata spoke of Tamil Nadu as being an outstanding example of reasonably good healthcare, and I can personally vouch for that. So you must also have noticed that regionally and from state to state, the kind of healthcare and the quality of healthcare delivery varies hugely among the states of India. Is this purely a function of governance, literacy? What is it due to that we have these wide variations? At one extent you have Kerala, whose indicators are comparable to that of the Scandinavian countries, and at the other you have places like Bihar and UP which are compared to sub-Saharan Africa. So why don't we have examples from within our own country and try and implement them elsewhere?
Well, you're absolutely right. I think I've been, discussing this with other colleagues for a long time, that why don't we really look at the Tamil Nadu model and see what really worked there. And it has to do with good governance also. I mean, I think whether or not it's a larger question of what other governance factors are working in the state, that's not the question. Whether in the health sector the governance indicators are positive, and there are ways in which the health system has functioned. Tamil Nadu health system has functioned well, so has possibly Kerala, and generally southern states have been doing well and other states have not been. So I think we have, from within our countries, we do have examples of what we can do, at least at the margins. I mean, how we can streamline the drug purchase, how we can actually work on the diagnostics to see that fair distribution is done, etc. But we don't do that, and there are also other inequalities. I mean, regional disparities is one, Mythili, but there are, if you look at the inequality in the health sector, it cuts across regions. It's there every which way you look at it, urban, rural, scheduled caste, tribes, minorities. What stands out in the health sector is huge health inequalities across all parameters. And somewhere this is because of poor governance, somewhere it's because of poor economic growth. There are multiple factors that affect whether or not the health system is able to deliver. One other thing that I really want to mention here is health system's performance. I mean, why do we have to, we often talk about changing, making health a fundamental right, etc. But why cannot we, in the current setup that we have, be more efficient and responsive to the needs of people? And that has always puzzled me, that it is not as though we have to overhaul the system every time we talk about inefficiencies. We can actually make the system much more responsive than it already is with the current level of spending. And so while stepping up spending is a very important thing that we have to do, even within the current spending envelope, I think there can be major changes that can be brought about to make the health system more functional and efficient. And that has been done in some states, and other states can follow their examples, but it won't be very easy, because because there are other parameters that need to be also set in place. It's not only the governance.
Sure, really, given how critical healthcare is to each one of us, I guess we could go on, but I'm afraid we've run out of time completely, so I'll really have to end this discussion now. We haven't got around to the issue of price control or the issue of implementation, but nevertheless, we'll have to end this discussion now. Thank you so much, Sujata and Indrani, for joining me in this discussion. Hopefully, the government will take note of the suggestions you've made and focus on what has always been our Achilles heel, implementation. Thank you also for watching. Remember, we'll be back next week with yet another edition of Macros with Mythili. In the meantime, if there's any issue that you'd like to discuss in this program, please do mail us at the mail ID you see at the bottom of the screen. With that, it's goodbye and thank you from all of us at ET Now.
Find us on Facebook at facebook.com/etnow and don't forget to click the like button. You can also follow us on Twitter at etnowlive. To stay updated with all our programming, hit the subscribe button on our YouTube channel by logging on to youtube.com/etnow.